Anemia in pregnancy is when the hemoglobin concentration is less than 11 grams per deciliter. That's according to World Health Organization, and is described as severe if the hemoglobin is less than 7 grams per deciliter. Anemia has adverse effects on the health of the woman and the outcome of the pregnancy, and is associated with an increased rate of miscarriage, preterm delivery, fetal growth restriction, fetal death, and increased perinatal loss. It is also associated with anti and postpartum hemorrhage and an increased maternal mortality rate. Ideally, no woman should go into labor with anemia. Appropriate measures, including blood transfusion, may be required to correct anemia, especially if a woman is close to her expected delivery date. The causes are physiological due to blood volume expansion in pregnancy, poor dietary intake of iron, folate, and vitamin B12, hemolytic disorders, for example, sickle cell disease, GSPD deficiency, as the effect, and also malaria infestations with hookworm, as ascaris, cystosomes, also chronic infections like TB, TI, HIV, bleeding complications in pregnancy, for example, APH. So the main symptoms are dizziness, swelling of the feet, general weakness, easy fatigability. The signs that are usually listed are mucosal pallor, jaundice, which may or may not be present, hepatosplenomegaly, and this may or may not be present, and heart failure in severe cases. Investigations are FBC, peripheral blood film comment, blood film for malaria parasites, sickling, and HB electrophoresis, GSPD, activity, serum iron, binding capacity, total iron binding capacity, ferritin also, and also stool analysis for hookworm over, urinalysis for cystosoma over, and urobilinogen. So the main treatment objectives are to relieve symptoms, to correct hemoglobin level before patient reaches term or goes into labor, to identify and treat underlying cause, to recognize and manage the associated complications in the mother, for example cardiac failure and baby, for example intrauterine growth restriction. The non-pharmacological treatment, you encourage intake of foods such as red meat, poultry, fish, dark leafy vegetables, shellfish, dried fruits, which are rich in iron, folate, vitamins B and C. Avoid tea, coffee, brown cola, and unhealthy habits such as eating of clay, which inhibits iron absorption. So encourage intake of folate and vitamin rich foods, including beans, avocado, citrus fruits, spinach, and mangoes. Also, protein rich foods must also be included in the diet, and ensure these anemic patients are seen more frequently in the antenatal clinic, and their response to treatment monitored with hemoglobin level checks. The pharmacological treatment, you give ferrous sulfate oral 325 milligrams 8 hourly, or ferrous gluconate oral 300 milligrams 8 to 12 hourly. You evaluate after 4 to 6 weeks, and then you give folic acid oral 5 milligrams daily, and blood transfusion. In severe anemia, HB less than 7 grams per deciliter, a blood transfusion may be necessary. And in labor, severe anemia is best treated by blood transfusion. When there is heart failure, preferably transfuse packed cells. Also add furosemide IV 20 to 40 milligrams if given whole blood. Referral criteria, so refer patients with anemia to a dietitian or diet nurse for counseling and support. And treatment for severe anemia with HB less than 7 grams per deciliter is best given in health facilities with blood transfusion capability. So all women who do not respond satisfactorily to oral treatment should be referred for further evaluation. For those with associated conditions like HIV and hemoglobinopathies, it should be managed in the hospital. HIV patients and HIV patients on antiretroviral medication may need modification of their drug combinations to exclude those that aggravate anemia. For example, zidovudine. Okay, so let's quickly look at the flow chart. You screen all pregnant women for anemia. You check hemoglobin level at booking and at all visits if possible. So if hemoglobin is less than 11 grams per deciliter, it's got to anemia in pregnancy. So do comprehensive assessment for underlying cause. So hemoglobin level 7 grams per deciliter or less, that's severe anemia, or women is symptomatic for anemia at any gestational age. And hemoglobin level 7 grams per deciliter or less, that's severe anemia. And when the woman is symptomatic for anemia at any gestational age, so that confirms anemia. So, and when after doing a comprehensive assessment for underlying cause, the hemoglobin is more than 7 grams per deciliter and but less than 11 grams per deciliter, so 7 to 11 grams per deciliter, so that's moderate anemia. And if gestational age is more than 28 weeks, you refer for delivery in hospital. Normally the HB goes to 7 grams per deciliter or less. And if the gestation is less than 28 weeks, so you give iron tablets 60 milligrams twice daily and folic acid 1 tablet 5 milligrams daily. And you give IPT SP doses during second and third trimester. You cancel on nutrition, deworm once after first trimester. You monitor closely and check HB at all visits until normal. You monitor fetal growth closely and you identify and treat other causes of anemia.